Good evening to all. Thank you for joining again with the session on critical care MCQ discussion for this week. So we'll start the second class. This class will be based on pulmonary thromboembolism. Last class, I think we discussed about the introduction ARDS. And this class will go towards pulmonary thromboembolism. Again, as I said in last class, we will not be learning about like the entire bedside management of pulmonary embolism. That's not the objective of this class. So this class will be purely based on the fact that we are looking for MCQs that are probably going to appear in your MCI exams, probably NEET SS or INISS, the upcoming session, and how to go about solving those questions. More or less be an introductory class on pulmonary thromboembolism. If time permits, in the end, we'll have another detailed class where we'll be looking at the trials and all the evidence of pulmonary thromboembolism. So moving forward, so similar to last class, we'll have a set of questions, and I would advise all of you to probably try solving those questions like how you would do in your exams. That will help you in two things. One is to test your underlying knowledge, which you can always work on. Second thing is to work on your question reading speed and your agility when you solve those exams. These are two things that probably you can actually help at. So as we move forward, I think that is what is going to be very important for you to solve your exam. Okay, we'll move forward. So the first question, in the DASH prediction score for recurrent VTE, venous thromboembolism, which of the following criteria has the highest positive impact on the cumulative score? A, male gender. B, age less than or equal to 50 years. C, abnormal D dimer 1 month after stopping anticoagulation. D, hormonal use at VTE onset if female. The four things is something called a DASH prediction score for the risk prediction score for recurrent venous thromboembolism. And it consists of four entities. So which of the following has the highest impact on the cumulative score? Do we have any responses? Something, I mean, like let's like how we did in last class. I would be useful if I get some responses so that we can work on the questions and why we see you're right or wrong. That will make the class much better. Right. Okay. So forward. So the correct answer is C. See, basically, I'll show you what the DASH score is, and then you'll probably get a better idea. As far as the DASH score is concerned, the mnemonic DASH stands for D dimer, age, sex, and hormonal use. So that's what DASH stands for. So looking very closely, D dimer abnormal at 1 month after stopping anticoagulation carries 2 points, while age less than 50 and male patients carry 1 mark. You look very closely, hormonal use gives you a negative point. You know why? That is because hormonal use is a reversible risk factor here. See, abnormal D dimer, you cannot reverse it. Age, you cannot reverse it. Male patient, there's nothing. These are all non-modifiable risk factors, while hormonal use being a modifiable risk factor carries a negative points, because if the DVT or venous thromboembolism because of hormonal use, I can always stop the hormonal pill or whatever the medication the patient is on. I can always reverse the risk factor for venous thromboembolism. So recurrent VT are lesser if patients would take hormones if stopped. So that is the reason why we give negative points for hormonal use, while we give positive points for D dimer, age, and male, and the highest points is for D dimer use in patients. So the correct answer is C, abnormal D dimer 1 month after stopping anticoagulation. And you look closely, an abnormal D dimer result adds plus 2 points, which is the highest positive among the criteria. Other factors like this at 1 point, and hormonal use gives you a negative of 2. I hope I'm clear with this. So now moving forward, a 45-year-old male patient has a DASH score of 3 after completing anticoagulation therapy for venous thromboembolism. What is the recommended management based on the DASH scoring system? No further anticoagulation required. Consider discontinuing anticoagulation therapy. Continue anticoagulation therapy and monitor without treatment. Any answers? So Dr. Malay should have things continue anticoagulation therapy. Okay, so we have a lot of C's coming out. The answer is C. I think I showed you on the last slide what it is and how you defect it. So to continue on the DASH score, based on the 4 criterion, what you do is you have an interpretation. Any score of 0 or 1 they have a low risk, so you discontinue anticoagulation therapy after completing the therapy of 3 to 6 months. While if the score is greater or equal to 2, you continue your anticoagulation because the annual recurrence risk is almost nearly 9 to 10%. Right? Okay. So going to the question 3, which of the following is not an inherited risk factor for pulmonary embolism? A. Factor 5 laden mutation. B. Antiphospholipid syndrome. C. Prothrombin mutation. D. protein C deficiency. Pretty straightforward question. So thing is, these such questions often come in your aims and NEET SS exams, where some factual questions are often asked, and you are supposed to like have a rote memory of all of this. Okay. Okay. So moving forward, see, look very closely. This is very straightforward, right? All of these are mutations. Mutations cannot be acquired. I mean, they can, of course, they can be acquired, but most of these are congenital, and the only acquired risk factor here, which cannot be inherited, is antiphospholipid syndrome. So the answer is basically antiphospholipid. So going to the, I mean, a short list of what are the inherited and acquired risk factors. Most often the questions are based on the inherited risk factors, while the acquired risk factors you just have to remember. So the major inherited risk factors are factor V laden mutation, prothrombin mutation, antithrombin deficiency, and proteinase deficiency. So question 4, which of the following symptoms is the most common? So patient comes to you, which of the following symptoms is the most common in patients with acute pulmonary embolism based on prevalence? So which symptom do most patients present with? A. Pleuritic pain. B. Dyspnea. C. Extremity swelling. D. Cough. This is also very simple, straightforward, but it is asked once in the previous year questions, because sometimes when you get such questions, you often get confused if it's just a, I mean, if it's a twisted question or if it's something very straightforward. So that's the reason I put this question here. So the answer is, of course, dyspnea. More than nearly 75 to 80% of your patients present with breathlessness, while the prevalence of pleuritic pain varies from 40 to 75%. Extremity swelling is usually rare. Usually only 25 to 30% of patients present with extremity swelling. And cough is much less common at around 4 to 43%. Moving forward. So this is now the patient has come to you. You have to assess the risk of severity. Which of the following factors categorize the patient into high risk group for early mortality in pulmonary embolism? A. PESI class 1. B. Shock or hypotension. C. RV dysfunction and cardiac biomarkers both negative. D. Intermediate low risk on PESI. So examiners, especially in most of these entrance exams, are fond of asking questions based on these risk stratification scores and all that in pulmonary embolism. So it's prudent to understand the scores and the management based on them. Yeah, somebody says B, shock or hypotension. It's pretty straightforward. High risk for early mortality is defined by the presence of shock or hypotension. One twist here is any patient with shock or hypotension, you do not have to worry about the PESI or simplified PESI score. PESI is pulmonary embolism severity index score. I'll come to the score in a while. So you will have don't, if the patient is shocky or patient is having hypotension requiring vasopressors, you definitely do not have to worry about the severity scoring or severity index. The patient is automatically in the high risk. That's the underlying statement here. So look closely here. The stratification is based on this. When you look closely here, your stratification is based on the PESI score. The highest risk is based on PESI class 3 to 4 or shock or hypotension present. So these are the two high risk groups. And RV dysfunction on imaging and cardiac biomarkers, all of them have to be positive. Patient should have shock or hypotension, but as far as high risk, regardless of PESI or a simplified PESI class or scores. Or if you're going to look at the PESI, which will come in a while, so a PESI class has to be 3 to 4. This here is an absolute score. Simplified PESI, you don't look at the class, you look at the score. While here you look at it, PESI class 3 to 4. And RV dysfunction has to be present, cardiac biomarkers have to be elevated. So these are the various parameters to say somebody is having a higher mortality risk and the high risk group as far as stratification are concerned. Similarly, you have changes as far as intermediate and low risks are concerned. As far as low risk is concerned, you look, everything is once you have a no shock and PESI class is less than or equal to 3 or 4 and score is less than 1, you don't have to assess further. So these patients are just low risk patients. The intermediate risk is where you have often a treatment or management dilemma, because these patients often fall into an intermediate high category or an intermediate low category. Intermediate high categories usually do not have shock or hypotension, but they have both RV dysfunction and elevated cardiac biomarker with a higher PESI class or higher simplified PESI score. While intermediate low, they do not have both RV dysfunction and cardiac biomarkers, but only one of them are positive. Okay? That is the differentiation between high, intermediate, and low risk. How do you classify, or how do you put the compute the PESI score? This is how the PESI score actually was a very complex score with a lot of parameters with high scores like 10, 30, and 10. So the overall score was somewhere greater than 140. So around 126 is what they say is the highest score, and any score above 86 is what we are looking for. So for high risk score, you're looking at 3 to 5. So 3 to 5 is the class 3 starts at 86. So any score greater than 86 is what we are worried about, because the mortality is more than 3% there. So that is what we are worried about. But to make things simpler, they came up with what we call a simplified PESI score. This simplified PESI score is basically based on age, history of malignancy, which is actually a very high risk factor for pulmonary thromboembolism, cardiac pulmonary diseases, heart tachypnea, hypotension, and hypoxia. These are the various risk factors based on which you classify them as simplified PESI score. Any patient with 0 points is low risk. Even if you have one of these positive, then you come under high risk. This is basically a highly sensitive mass score, but not a specific score. That's the idea here. Because this is more of a screening score, so you don't have any high of more of sensitivity and less specificity. Okay, am I clear here? Okay, I'll move forward. I mean, this question I don't want you to answer. I mean, this is not. I'm not worried about the right answer. The reason I put up this question is questions can come like this once in a while, very eccentric. But my genuine advice would be, don't waste your time on such questions if you do not know the score. If you do not know how to calculate it, please leave that question, or don't waste too much time preparing for all these scores. I mean, analyzing all the parameters and knowing how many points are there. Usually not worth it, because you're going to get 1 or 2 questions maximum, but you'll have to waste too much of your brain space. So that's the reason I put up this question. This question is not to tell you how to read, this question what not to read, or if you have less time, don't waste your time on these questions. So a patient with a temperature of 6 degrees Celsius and tachycardic, how would you, how many points in the PESI score? This is not simplified PESI, this is PESI. The answer is basically, just a second. So, yeah. So the answer is basically 70 points. You add up all of this based on the previous parameter I told you, and that basically gives you the score. So based on whatever data I've given, if you add up all of this, the score comes at 70. So 70 would be class 2. We'll go to the next question. Which of the following is not a criterion in simplified PESI index? So I just told you about the various parameters on simplified PESI. Can somebody answer it for me? Age more than 80 years, systolic BP less than 100, alternate mental status, and oxygen saturation less than 90%. C. Okay, good. So I'm happy, like, some point has been driven home. Yeah. So alternate mental status, I don't know, for some strange reason, when they devised the simplified pulmonary severity index, they have removed alternate mental status. Probably it is made to just, since it's a more sensitive score and not a specific score, they might have removed it, but I'm not very much aware about what the reasons are. And there's no literature as to why they removed certain parameters and kept few. But based on whatever is analyzed, the parameters that are present are age, history of cancer, history of chronic cardiopulmonary disease, heart rate more than 110, systolic BP, tachypnea, hypotension, and hypoxia. All three are strong parameters indicating toward the pulmonary embolism. So those parameters are retained. Alternate mental status actually in the original PESI score had a high score, had almost 60 points. But now in the simplified PESI score, that has been removed. The reason I can think of is usually alternate mental status occurs very late. I mean, only when patients having profound shock, when they have extreme hypotension, where there's hypoperfusion state, that's when, or extreme of hypoxia, that's when they start developing alternate mental status. So since it's a very late presentation, I believe they would have removed it as a part of the simplified PESI score. Okay. So if you've diagnosed pulmonary thromboembolism, what's the initial dosing regimen for enoxaparin in the treatment of venous thromboembolism? So this is a treatment dose I'm asking for. Initial treatment of venous thromboembolism, what is the initial dosing regimen? A, 5 to 10 mg daily. B, 80 units per kg bolus, then 18 units per kg per hour infusion. C, 1 mg per kg BD, that's 12th hourly. D, 15 mg BD for 3 weeks. That's a very straightforward question. Anybody who's worked in reasonable ICU or in the perioperative setting would be aware of this. You usually dose it at 1 mg per kg. Just remember the various anticoagulants that are available and the proper dosing and how you monitor them. Any of this can be asked potentially. Usually, unpractioned heparin you do not prefer all the time, except in patients with severe renal dysfunction and where you want to titrate and reverse it quickly because you have protamine available. If you want to reverse, if you feel the patient has high risk for bleeding and there's possibility of reversing, then you use unpractioned heparin. Otherwise, you go for low molecular weight heparin. And these are the corresponding doses and the monitoring. Usually, unpractioned heparin you monitor using APTT. While the low molecular weight heparin, you don't need to monitor, of course, but except in warfarin. Warfarin is not a very great choice in the ICU because you give it orally. Any oral drug in the ICU might not be a great choice because you're not worried about you are not sure about the absorption because you are giving a lot of drugs. You are not sure about the interactions and all that. So usually better to avoid the oral drugs inside the ICU. So stick on to subcutaneous and then switch over to the oral drugs when the patient is being discharged. Okay. What is the baseline risk of major bleeding after 3 months of anticoagulation for a low risk patient? I'm very sorry for this question because this question was asked a few years ago. I mean, not the exact question, but such a kind of question was asked. So you sometimes can come up with such questions. The only thing is here is they do not ask for all the numbers. You just have to remember the low risk and high risk. That's the idea here. They don't expect you to remember everything. Just just to show you the difference between how stark the difference between a low risk patient and high risk patient is. This question has been asked. Moving forward, the baseline risk, even for a patient who is low risk, is 0.3% per year. So even for a patient who has absolutely no risk of developing a venous thromboembolism, the low risk is around 0.3% per year. It's still not zero. So look closely. This reason for this slide is to show you what are the various risk factors for what are the various risk factors for bleeding with initiation of anticoagulant therapy. Any elderly patient, especially more than 65 or 75 years of age, patient who's having a previous bleeding episode, and all these factors, all these failure conditions, metastatic tumors, anemias, recent surgeries and falls, alcohol abuse, and non-steroidal antiinflammatories. All of these conditions are basically either they can actually cause pro-hemorrhagic conditions or conditions that can actually alter your coagulation cascade. These are the kind of factors that are usually possibly going to affect increase the risk of bleeding with initiation of anticoagulant therapy. So based on that, I don't want you to remember all these numbers. Just look closely. Once you give your anticoagulation for 0 to 3 months, after that, your baseline risk slowly starts coming down. You look here, anticoagulation after 3 months from 0.6 has come down to 0.3, from 1 it's come down to 0.5, and 1.6 come down to 0.8. So everywhere it's actually getting halved. Your the risk at the initiation of anticoagulation, and after 3 months the risk actually starts kinds of comes down. So with more therapy, you're actually with prolonged therapy, your risk of bleeding actually starts coming down. So the maximum risk of bleeding is usually within the time where you have initiation of anticoagulant therapy is. That's when you have the maximum risk of bleeding. So that's the point I want to drive home here. And the lowest risk after 3 months is around 0.3. And the highest risk is somewhere at around 6.5. Remember just these two numbers. It was asked once. Okay. Which combination of factors would categorize a patient into high risk group for major bleeding? I just told you. The answer is a patient with 2 or more risk factors, especially like thrombocytopenia and non-steroidal inflammatory drug use. So these are two major risk factors. So among all the available risk factors, thrombocytopenia and NSAIDs have the highest potential for risk of bleeding. We'll go to more useful questions. Which of the following is considered a major contraindication to fibrinolytic therapy? Something straightforward. Elderly with age more than 75 years. B. Therapeutic anticoagulation. C. Recent head trauma with fracture or brain injury. D. Systolic blood pressure more than 180 mmHg. Anybody who's worked in a recent reasonable emergency setting or who has worked in ICU would probably know this. Systolic BP more than 180, recent head trauma with fracture or brain injury, therapeutic anticoagulation, age more than 75 years. Yeah. The correct answer is C. Look closely. Your systolic BP more than 180 is actually a relative contraindication. It's not a major contraindication. You can always bring the BP down and thrombolyze these patients. But absolute contraindications are any intracranial disease which is structural, previous intracranial hemorrhage anytime, recent ischemic stroke within 3 months because you can have an intra-stroke bleed and active bleeding at current point, recent brain or spinal injury within the last 3 months, usually they say in the last 3 months, recent head trauma with fracture or brain injury which can always re-bleed, and patients who already have an established bleeding diathesis. So these are the conditions where you do not thrombolyze the patient. Everything else I told you and all the options I told you are all relative contraindications and they're not absolute contraindications. Always, if you're not sure, go through the checklist and then thrombolyze. This is for more of a clinical practice. When you're not sure, go through the checklist and then thrombolyze any patient. Patient 12. In the management of acute pulmonary embolism, what is the first step for a hemodynamically stable patient? A. Perform thrombolysis. B. Initiate the orbital infusion. C. Anticoagulate or place an IVC filter if anticoagulation is contraindicated. D. Proceed direct to surgical thrombectomy. Usually, patients in pulmonary embolism usually they present to you either stay with stable hemodynamics or unstable hemodynamics. I'll go through the protocol or the algorithm of management of pulmonary embolism in a while. But usually, to start with, they present either in hemodynamically stable fashion or extremely hemodynamically unstable fashion. Among all the available management options, which would you choose first? I have a somebody says perform thrombolysis. Okay. All right. Anticoagulate plus an IVC filter. Right. Okay. So the right answer is anticoagulate or place an IVC filter. This is where most people get confused. So listen carefully. So when you look at this very closely, you look at this, then a patient can present acute pulmonary embolism. Once they present acute pulmonary embolism, as I told you, they can be hemodynamically stable or hemodynamically unstable. The question was about hemodynamically stable part. So once they're hemodynamically stable, there's no role for thrombolysis. Drive it straight into your head. You do not thrombolyze a patient who's hemodynamically stable as of the current guidelines are. Once they're stable, the initial management would be to anticoagulate and play. If you cannot anticoagulate them because for many reasons they might be bleeding or they could be risk of they could be taken up for surgery the next day. There's so many reasons. So if you cannot anticoagulate them, you place an IVC filter if anticoagulation is contraindicated. If worsening, then you have to switch the mode to the unstable arm. The next thing you do is you assess for RV strain using the echo. If you have features of RV strain on the echo, then you do you treat as unstable. If they do not have an RV strain, you continue the anticoagulant therapy. Meanwhile, recent guidelines also say, apart from echo, you also do a BNP and troponin because BNP and troponin are markers of myocardial stretch. Once you see that there is elevated BNP, brain natriuretic peptide, and troponin, you know that there is an excessive strain on the RV. So if there's an enlarged RV or RV strain on echocardiogram with an elevated BNP and troponin, you go ahead and say probably this patient is going to become unstable. That is what previously was called as submassive pulmonary embolism. Massive pulmonary embolism was a patient who presented with shock, hypotension, or cardiac arrest. Submassive pulmonary embolism was a patient who presented with RV dysfunction but who did not have hemodynamic instability or shock. So that was how we previously classified it. And even now, many authors use those terms like massive PE and submassive PE. So any massive PE, you thrombolyze. Submassive PE is you take a bedside decision to thrombolyze. If the patient is worsening, of course, you go ahead and thrombolyze if there are no contraindications. All the other patients go towards the anticoagulation arm. You don't thrombolyze them. So that is how you treat this patient. So if you have always thought you have thrombolyze these patients, if they are hemodynamically stable, always defer thrombolysis. Alright? Okay. What action is recommended if a hemodynamically stable patient with acute pulmonary embolism is found to have an RV strain? A. Continue current therapy. B. Treat as unstable and reassess management. C. Initiate thrombolysis. D. Proceed directly to thrombectomy. I just told you the answer for this. So if you say initially the patient is hemodynamically stable, you perform an echo and you find an RV strain, what do you do? So you see, we have an answer B. Dr. Arnab says it's B. Treat as unstable and reassess management. Others? B is right answer. I just told you. Once you say the patient is hemodynamically stable, but your echo is showing an RV strain, you treat them as unstable, and the patient switches over from this arm to provide initial resuscitation. Which intervention is indicated? A. Thrombolysis or thrombectomy based on local expertise. B. Place an IVC filter. C. Continue anticoagulant therapy. D. Perform an echo at this point to assess for RV strain. We have a couple of A's. Okay, a lot of A's. So yeah, I've told you very clearly, if a patient is hemodynamically unstable, which was previously called a massive pulmonary embolism, you go ahead and thrombolyze the patient straight away. In centers, a few centers who have the expertise to do a local thrombectomy, you can always go and do a mechanical thrombectomy in the pulmonary artery. The correct answer is A. So as I told you here, we'll come to this side of the arm now. Hemodynamically unstable is usually shock, hypotension, or cardiac arrest. If the patient is having cardiac arrest, it's a different management altogether. We'll come to that in a while. If the patient is not having cardiac arrest but is unstable, you resuscitate, assess for RV strain, and then you anticoagulate and place IVC filter. If they have an arrest, you straight away thrombolyze them. If there's a continued hemodynamic instability, despite all of this, you thrombolyze the patient, and then if they continue to remain unstable despite thrombolysis, you go ahead and do a thrombectomy. That's how the procedure goes. Patient comes to you, you diagnose PE or suspect PE. Patient is hemodynamically stable. I told you what. Hemodynamically unstable, you see if the patient is having cardiac arrest or not in cardiac arrest. In cardiac arrest, straight away thrombolyze, consider extracorporeal life support, and continue resuscitating the patient. This is one indication where you can do a prolonged CPR. Pulmonary embolism is one classical indication where you can do a prolonged CPR because it is pretty much reversible and you have a good chance of recovery despite the patient having prolonged CPR. It's been shown that. So one indication where you can do a prolonged CPR is pulmonary thromboembolism. Once the patient is not in cardiac arrest, you resuscitate, you assess for all the features of RV strain and the echo and biomarkers I told you. And if the patient continues to remain hemodynamically unstable despite resuscitation and all that, then my management would be to move towards thrombolysis and mechanical thrombectomy accordingly. All right. So 65-year-old patient with a confirmed acute pulmonary embolism presents with hemodynamic instability, including hypotension and shock. The patient undergoes thrombolysis, but there is no improvement. I just told you what to do. What are we supposed to do? What are the next appropriate step in management? A. Continue anticoagulation therapy. B. Perform thrombectomy or consider ECLS. Place an IVC filter. Or D. Repeat thrombolysis. This time I have a couple of B's. Perform thrombectomy or consider ECLS. Perform thrombectomy. Yeah. All right. Good. So we've just discussed what to do. Look at the lower part of the arm now. Thrombolyzed, patient continues to remain hemodynamically unstable. I have done a thrombolysis. If it is successful, I can continue anticoagulation. If it's not successful, I can assess for a thrombectomy or a ECLS at this point, right? Okay. But if I perform a thrombectomy and if it is not successful, my only option is to look for ECMO, that is extracorporeal life support. This is how the algorithm for treating a pulmonary embolism patient goes. A 50-year-old man presents to the emergency department with sudden onset shortness of breath and chest pain. The physician suspects acute pulmonary embolism. What is the first step in managing this patient? A. Perform transthoracic echocardiography. B. Assess for hemodynamic stability. C. Conduct a multi-detector CT scan. Or D. You seek alternative diagnosis. I have a very quick answer this time. B. Okay, I have one A here. Okay, and B. Okay, one person has said A, while others have said B. Yeah. So the answer is B. So, see, I told you very clearly, right? The first step in managing any patient, the algorithm says assess for hemodynamic stability. Only if you know if he is hemodynamically stable or not, you proceed further. Without if the patient is hemodynamically unstable, you don't even have to perform an echocardiography and you can straight away thrombolyze the patient. So that's what the algorithm says. So patient with suspected PE, assess for stability. Hemodynamically unstable, then you do a transthoracic echo, then you proceed towards whatever algorithm we spoke so far. The patient is hemodynamically stable and shiftable to a CT, you can shift him to a CT, and based on the positivity or negativity of CT, you can treat the patient accordingly. But the first step at all points of time is going to assess for hemodynamic stability. Only after you know the hemodynamic stability, then you move towards doing a CT or echocardiography. Very important. The first step is always A, B, C. Critical care, the first step is always A, B, and C. After that is when you actually move towards managing any patient. Is the most appropriate approach when administering intravenous fluids. A, large volume bolus of 1 to 2 liters of IV crystalloid should be administered rapidly to increase cardiac output. B, IV crystalloid should be administered in small volume boluses as a cautious fluid challenge to improve cardiac output. The aggressive administration of fluids is recommended to rapidly restore circulatory volume and improve blood pressure. The administration of IV fluid should be avoided altogether in hypotensive patients to prevent fluid. Okay, I have one B here. Dr. Priya, she says it's B. IV crystalloid should be administered in small volume boluses as cautious fluid challenge to improve cardiac output. Okay, so I have a lot of support for B. Good. So a small take on the physiology here. See, you know that pulmonary thromboembolism is basically an obstructed right ventricular outflow, right? Right ventricular outflow is going to get obstructed. So the problem here is when I give more fluid, the preload to the right heart is going to increase. Once I increase the preload to the right heart, a struggling RV might not be able to pump it further, and it can cause the septum to push towards the LV, and that will also reduce the LV filling and the LV output. So it's going to cause a reduced cardiac output, and that reduced cardiac output is going to end up in shock. I hope I am clear. So you have a patient with pulmonary thromboembolism. Their RV outflow is less. Once their RV outflow is less, depending on patient status, when you increase the RV preload, the RV sometimes when it's not able to pump beyond a certain resistance, slowly going to retain the fluid inside the RV. So slowly the RV septum is going, the interventricular septum is going to shift towards the left ventricle. Cardiac output starts coming up, and that causes shock. This is how these ways I end up with shock. So if I'm going to give as an option A, a large volume bolus of 1 to 2 liters, I might precipitate a sudden RV failure and RV strain, which I'm not supposed to do. But however, many of these patients can still be hypovolemic. So if I have to assess for fluid status, I would give a small bolus of 250 ml usually, and then repeat the fluid status assessment and then treat accordingly. Very important to remember that never be aggressive in fluids. At the same time, it's not that you're not supposed to give fluids at all, but be very cautious with fluid in this patient, especially very guarded boluses with every time before and after giving a fluid bolus, check for preload assessment. We'll have a separate class on preload and after assessment and hemodynamic monitoring. But yeah, this is how you are supposed to give fluids in a patient with any RV failure, not only pulmonary embolism. RV failure patient, usually you start treating like this, but more so in pulmonary embolism. Right. So identify the diagnosis based on a CT image. So sometimes you have image-based questions, like this one-line image-based questions that come in the exam. You usually have around 10 to 15 of them. Usually, but always varies between sessions. So A, saddle embolus. B, right main pulmonary artery embolism. C, left embolism. Left main pulmonary artery embolism. Sorry for the typing error there. D, normal CT with no P. So all of you say it's saddle embolus. Great. Look closely here. There is no obstruction. There's no flow both sides, right? It's just sitting at the right at the bifurcation. It's not flowing both sides. So it's saddle embolus. Right. And you have look distally. None of the segmental or subsegmental branches have the dye. There's complete block. So there is complete pulmonary oligemia, and there is even the main pulmonary arteries are not perfused. Only the proximal pulmonary arteries having the dye, and it's not flowing beyond that. Right. Last question. Diagnosis based on the given echo report. Acute LV dysfunction, acute RV strain, C, LV thrombus, D, mitral valve thrombus. Since it's a class in pulmonary embolism, it should be a very easy answer. Okay, have somebody say acute LV dysfunction, somebody say the acute RV strain. Anybody else has an answer? So we have a couple of see, this is an apical four-chamber view, not the best of the not the best of the views, but yeah, it's an apical four-chamber view. This is the RV, this is the RA, this is the LV, this is the LA. Interventricular septum. Look at the RV is supposed to be usually smaller than the LV. Once your RV becomes as big as or bigger than your LV, you know the RV is struggling to contract, and the RV here is huge. It's bigger than the LV. LV is so small, and the LV is almost nearly D-shaped. You look at this, the LV is almost D-shaped here, and the RV is so big. So the septum is slowly being shifted towards this side. The LV is becoming D-shaped, and the RV is slowly beginning to enlarge. So this is how you. And if you put a Doppler here in the tricuspid valve, you find a massive TR in these patients, and a pulmonary because there's a lot of resistance to right ventricular outflow tract. So you'll be finding a severe TR or even mild to moderate severe TR, and you'll be having a significant LV strain here with RV dysfunction. Okay. So that brings us to the end of the introductory class on pulmonary embolism. So we have a lot of other things to discuss in pulmonary embolism, like your the trials and all that. But we'll see if we'll have one session on these respiratory trials and cardiovascular trials moving forward. But this being an introductory class, I just wanted you to show what are the kinds of questions that are often asked in pulmonary embolism and this topic as in your exams usually. So any doubts or any feedbacks, suggestions? Any feedbacks or any doubts based on this class or the last class on ARDS? No doubts? Any suggestions or any inputs? Okay. So we have two doubts here. If thrombolysis doesn't improve the condition, you mentioned ECLS, what is it, sir? So ECLS is basically extracorporeal life support, what we call ECMO. Normally we call ECMO, right? So ECMO or your right heart's mechanical circulatory support devices. That is what ECLS is. Extracorporeal life support. That is ECMO. We'll discuss about ECMO. So ACLS is basically ECMO. You have to temporarily support the heart, both the LV and the RV, and then wait for it to recover. That's why you use ECLS. It's more of a bridging therapy. Well score, yes, can be used. It's a good score to use. See, there are two. That's what I told you. There are two minutes scores in pulmonary embolism. There is Geneva criteria. There is Geneva score. There is a Caprini risk score. There is a Well score. There's something called um, a PESUDA score. There's so many scores. There are like around 7 to 8 scores in pulmonary embolism. But just mentioning all these scores in this one class would probably overload all of you. And always, if you want to remember, you can remember all these scores. But again, the idea of in a class like this, I thought probably it would not be the best of idea. The idea was to tell you there are different scores, and probably what depending on your brain space, you can remember the scores that you want. There's different scores for different patients. For cancer patients, there are certain scores. For non-malignancy, there are separate scores. Perioperative settings, there are separate scores. So they have all been validated in various conditions. So the idea here is to just tell you there can be questions based on scores, but usually the idea is not to test your rote memory, but just to say how to think about going an MCQ. That's it. Thank you.